Welcome back to Decode Healthcare with Harshal for our brand new explainer. So in part 6, we spent our time looking through those tiny incisions using VATS cameras. But today we're putting away the cameras and cracking open the chest cavity to decode massive lung resections. We're going to focus strictly on lungs and pleura excision and resection, and we'll be covering the critical open procedures found right in your CPT codebook. Here's a quick look at our roadmap for today. We'll start with opening the chest cavity, break down the lung tree anatomy, dive into wedge and segment resections, scale up to lobectomies and pneumonectomies, tackle the intense extrapleural pneumonectomy, and wrap up with a teaser for our grand finale. All right, let's jump straight into section 1, opening the chest cavity. We are shifting our focus entirely to open surgical procedures today. You know, when a surgeon makes a major thoracotomy incision to literally open up the chest wall, it requires a totally different mindset for accurate medical coding compared to those endoscopic or VATS procedures. Looking at the excision and removal guidelines straight from our CPT codebook, it's pretty clear how strictly these codes are divided by the sheer volume of tissue removed. I mean, from a tiny diagnostic biopsy all the way up to pulling out an entire lung, the CPT book segments these with absolute precision. Moving right along to section 2, anatomy, the lung tree. Okay, before we can even think about assigning codes, we absolutely must master the underlying anatomy. If you don't know your lobes from your segments, you simply cannot code lungs and pleura accurately. It's really that simple. You can clearly see the right lung and the left lung branching off from the trachea here. And here's a fun fact. Notice the size difference? The left lung literally has to surrender space to make room for your beating heart. Because of that, it only has 2 lobes. The right lung, on the other hand, has 3 distinct sections, the superior, middle, and inferior lobes. To make this super easy to remember, just think of the lung exactly like a tree. The main, thickest branches coming off the trunk, those are the lobes. Now those main branches break down into smaller anatomical twigs, which we call segments. And finally, at the very ends of those twigs, you have the tiny leaves, which surgically we refer to as wedges. The CPT codes we're exploring today are strictly divided by exactly how much of this tree the surgeon chops off. Section 3, wedge and segment resections. So let's look at how we actually code for the removal of those smaller leaves and twigs. This right here is the foundation of our lung resection codes. The crucial thing to understand is the physical difference between the cuts. A wedge resection is basically just the surgeon cutting out a tiny pie-shaped wedge of lung tissue from the outer edge, usually just to biopsy a suspicious nodule. A segmentectomy, however, follows strict anatomical boundaries to remove a whole segment, an entire twig, while carefully leaving the rest of the lobe intact and functioning. Pulling straight from our coding tables, notice the clear, undeniable distinction between code 32505 for a therapeutic wedge resection and code 32484, which you use when a single anatomical segment is completely removed. It's a completely different level of surgical dissection, and your coding must reflect that massive jump in complexity. But what happens when the surgeon takes even more? That brings us to section 4, lobectomies and pneumectomies. Let's scale things up and see how this builds when the surgeon starts removing entire branches or, wow, even the whole tree. We are now officially entering the territory of major open lung excisions. A lobectomy takes out one full lobe, so one of the 3 on the right or one of the 2 on the left. But a pneumolectomy, that is a massive open surgery that removes the entire lung, typically for severe, widespread disease like advanced lung cancer. Picture a post-pneumonectomy chest x-ray. Instead of 2 black, air-filled lungs, one entire side of the chest cavity appears completely solid and white because the lung has been completely extracted. Looking precisely at the code book, you've got to scale up your codes based on the exact anatomy removed. You report 32480 for one single lobe. If the surgeon takes out 2 lobes, let's say the middle and lower lobes on the right side, you'd report 32482 for a bilobectomy. And when the whole lung comes out, reaching the absolute top of our scale, you hit 32440 for the full pneumonectomy. Always let the volume of the tissue dictate your code. Section 5, the extrapleural pneumonectomy. Now, knowing what to do when the cancer is so severe that just removing the lung isn't enough, that is a defining skill for an expert coder. For highly aggressive conditions like mesothelioma, surgeons have to perform an extrapleural pneumomectomy. I want you to remember this simple formula for code 32445. It includes the total removal of the lung, plus the surrounding pleural sac, and even part of the diaphragm, all in one massive, intense operation. As you can see right in the guidelines beneath 32445, Coders have to be incredibly vigilant for add-on codes here. If the tumor has invaded the ribs and the surgeon also removes part of the surrounding chest wall, you need to look for specific combination codes or add-ons to capture that chest wall resection. Seriously, never ignore those parenthetical notes. They are your best friend. Finally, Section 6, a quick teaser for our grand finale. We have truly scaled the heights of open excisions today, going all the way from tiny pie-shaped wedges to pulling out the entire lung tree. But guess what? Our journey through the respiratory system isn't quite over yet. In our grand finale explainer next time, we're going to tackle the final code range from 32701 to 32999. We'll be diving into incredibly complex procedures like stereotactic radiation, surgical collapse therapy, and yes, double lung transplants. Think about it. If removing an entire lung and its sac is a massive code like 32445, how in the world do we accurately code the delicate process of putting a brand new donor lung back in? Think about the immense surgical skill required to reconstruct those vital airways and blood vessels from scratch. Make sure to subscribe and join us next time on Decode Healthcare with Harshal as we decode the ultimate respiratory procedures. I'll see you there.